complications associated with pacemaker implantation. And this is just a continuation of what Professor Sharif was presenting. He spoke about access issues, like pocket creation, pacemaker lead placement. So whatever I'm going to present is related to what he was talking about, but also lead testing for threshold and other parameters. So the incidence of pacemaker complications varies between 3 to 6%. But as you could know, it depends and it's difficult to determine because there are different definitions of what are the complications. But also, majority of the data which we are getting from these complications are mostly retrospective studies. So, but with the little modern information, we have some based data in large scale, prospective data and meta-analysis. So these complications can be early and late. A majority of complications occur in hospital or during the first 6 months. So when you talk of early complications are those which occurs between 6 to 8 weeks. And as you can imagine, as time goes on, the complication rate does decrease. And compared to the 2006 and 2010, there was a decline in overall rate of complications. But for female and elderly, the rates still are high. And you can imagine when center implantation volume is high and the rate of complications are low. But also operator experience determines complications. So they are divided into 2 major groups, the non-electrical and electrical, but also whether they are late or early complications. For non-electrical complications are basically the ones which Sharif presented, those who are associated with venous access, like pneumothorax, as he was showing you that you have to do some puncture to the different vessels like subclavian. But with the cut down, the cephalic vein cut down, there are issues with venous access, like complications does not occur. But also issues related with pacemaker pocket, like infections, hematoma, Gibbs syndrome, and others. Those which are associated with intravascular, like thrombosis in the veins, it can cause dissection, sometimes perforation, later causes pericarditis. But there are complications which are associated with lead problems, like dislodgement or accessory muscle stimulation, because there's a lot of hiccups, and also Fabian crash syndrome. Electric complications are basically associated with leads, and this can be failure to pace the appropriate cardiac chamber, which can be output failure or capture failure. But the problem with detecting intracardiac signals, we call it undersensing and oversensing. These occur in about 3% of patients. But others are pseudo malfunctions with different names, like rate-related, AV interval or refractory period related, and model related, like MVP mode. But there are also those associated with lead problems. If you have loose connection, I think PIP was fast, but sometimes it was also to show you that you need to tight the lead so that you can get good contact, and you can also get lead fracture. And as you can imagine, lead complications are the main reason for the operation after implantation of a pacemaker. So the most common complications after pacemaker implantation, most common are lead dislodgement, followed by pneumothorax, infection, and sometimes in also death, and early mortality, like that occur in less than 6 weeks. So with non-elective complications, the incidence of pneumothorax is about 2%, And risks are those related to age, subclavian vein puncture, female, experience of the operator, if you have lung disease, and the implantation of dual chamber vis-a-vis single chamber pacemaker. You cannot easily detect pneumothorax by auscultation, but also doing a chest X-ray. That's why chest X-ray is mandatory soon after implantation of a pacemaker. The management is not, and if it's massive, you do aspiration, but most of them are done conservative, but may need underwater seal drainage in serious cases. Perforation occur in about 1% of patients, and the most are asymptomatic. But subclinical may occur in up to 15% of patients. It can be acute or subacute, and with atrial perforation are rare. Mostly is ventricular perforation because of the ventricular lead. You can position it in the pericardial space. And this may be asymptomatic or can cause chest pain. And you can also see some failure to pace immediately after the implantation, and it can cause diaphragmatic pacing. Again, investigation includes chest X-ray, echo, and ECG. The ECG, you're going to see a right bundle branch block because the lead will now be stimulating left ventricle. And also treatment will include lead repositioning, management of associated complications. Bleeding can occur and it can be serious, especially when associated with the presence of antithrombotics. Dr. Sharif spoke about the reverse of anticoagulation, that in the past, it really used to be serious. Some people were supposed to reverse anticoagulants, but I think as with the experience, it's not necessary. As he said, there is issues of bridging or continuous Coumadin for device surgery, and this was a randomized control trial. And what they observed, there was no, is in primary outcome, significant hematoma will occur in patients with heparin bridging vis-a-vis with the continued warfarin alone, but also other issues like hematoma prolongation, hospitalization, hematoma requiring interruption to intercoagulation are different when you compare heparin bridging vis-a-vis continued with warfarin. I think this would be needed to discuss because Sharif presented on this that we no longer need to reverse anticoagulation. But for somebody who is on anticoagulant, some measures need to be taken to avoid coagulation. But for other anticoagulants with low risk of thrombotic events, there's no data, but some people suggest that you continue for 2 days. And when you have on low molecular weight or high molecular weight heparin, you can miss the dose for 24 hours before and you measure FPTT. And for new oral anticoagulant, you stop for 1 to 2 days and there's no bridging. But management is controversial as Habib presented because you need to individualize decision with patient based on estimated risk of bleeding with this thrombotic event. So other complications are infection, local device infection in the pocket or cardiac-related device infection. These are common and really they carry a lot of mortality. It occurs in 1 to 2% of patients. And it can be patient-related or procedure-related. Patient-related are like comorbidities, but also procedure-related include prolonged procedure or pocket hematomas, box change, and others. So infection, to me, is something which need to be really addressed. And all measures to avoid infections are important because when infections occur, you have to remove everything, remove the device and the wires. And diagnosis, you need high index of suspicions. As you can see the photo there, you have some signs like of local inflammation, but you can do other investigation like blood samples, blood culture, and imaging. And treatment is complete hardware removal. You remove everything. Accessory muscle stimulation can occur. It can be a diaphragmatic stimulation or left intercostal muscle stimulation due to perforation, and the pectoral muscle stimulation, which causes twitching. So we've been observing this, and it can be managed. Management includes decreasing output voltages, preservation of adequate safety margin. Lead displacement or dislodgement is another complication, and these are the commonest. It can be early or late, and it causes capture failure or undersensing. Investigation or diagnosis of lead displacement or dislodgement include chest X-ray, EKG, and the echo. Subclavian crash syndrome occur when someone puncture two when the lead is placed between the first rib and the clavicle. And to management of this, you have to puncture two midi. So, I mean, you have to do a lateral subclavian puncture or cephalic vein approach. So this can occur, especially when you have put your lead in the more middle between the first rib and the clavicle. Issues with different access, as Sharif presented to you, cephalic vein, subclavian vein, or extrathoracic subclavian vein or axillary vein are different. But like in cephalic vein, one needs to have a most surgical skill because it needed to be cut down, and the risk of pneumothorax is low. Risk of lead crash is very low, and you don't need fluoroscope for that. And also, but passage of the lead, especially when multiple lead, because now you have one cephalic vein and you need to pass two leads, for example, this may be difficult. But also, if you need extraction, also it may be difficult. So it is safe and very good one, but it has some complications, I mean issues or difficulties when compared to subclavian vein or axillary vein approach. Fidra syndrome is also another complication, and occur mainly in elderly and obese when the lead is tightly twisted upon itself and cause tension. And the management of this is to fix the box. As you can see in the pacemaker, pacemaker battery, you have a box. So if you can fix that in the hole, you can avoid Fidra syndrome. But some people like experience it, like now Professor Meva does not fix it because she's experienced and probably there are some other methods to avoid Fidra syndrome. So those in short were a mechanical complications or non-electric complications. In the next 5 minutes, I will be presenting on electric complications so that we can leave time to French people to also speak. So with the mechanical complications, one can be output failure, whereby the causes of missing stimuli during VVI pacing, and is suspected when the programmed heart rate, the heart rate is lower than the programmed lower rate of pacemaker, or when you have absence of pacing spikes. As you can see on the left side, that you are supposed to have a pacemaker, should pace, but it's not pacing. So this is output failure. And the causes are many. I cannot go throughout all of them, but loose connection is among them, lead fracture is among them, and the others. Capture failure, you now generated the pacemaker stimuli, but does not initiate the coagulation of atrial or ventricle. The causes are functional, like stimulation to the myocardial refractory during myocardial refractory, or electrode tissue interface, like lead displacement, emphysema, some drugs, electrodes problem, like insulation issues or screw or fracture of the lead. but also those associated with pulse generator, like incorrect programming, or the use of electro altering. Under sensing is another electrical complication whereby pacemaker does not see the intrinsic beat or does not respond appropriately. And if an unneeded pacer spikes, falls, and T wave, it sometimes can cause complications like VFib, ventricular fibrillation or tachyarrhythmia. The cause of undersensing one is lead associated like malpositioning or malfunction, the lead like fracture or insulation problem or dislodgement, but issues with electrolyte. That's why measuring or doing electrolyte levels like potassium is important, or when you have acidosis, can cause also undersensing. But also issues myocardial scar at the paste site. Treatment of undersensing is to increase sensitivity during programming. Oversensing, here an electrical signal other than the intended P or R wave is detected, inhibit itself from pacing as it would a true beat. The causes are many, including physiological signals like the T wave or far field event, skeletal malpotential, but also non-physiological signals like EMI and also lead associated. You have unipolar vis-a-vis bipolar, but also malfunction of the lead, including lead fracture and insulation problem. The treatment of undersensing is to reduce the sensitivity. And these are examples of oversensing and undersensing. But in oversensing, you are seeing too much, while in undersensing, you are seeing too little. And then for oversensing, you have to reduce the sensitivity, and for undersensing, you have to. There are some complications which are magnet rate, like magnet rate response, and this can be due to close the read switch, as synchronous mode or no sensing, and therapy for PMT and the end of ERA. Pacemaker mediated tachycardia is another common complications. It's a normal function but incorrect programming. And it is similar to the infant tachycardia, except that the pacemaker forms part of the intersect. Tachycardia could then be avoided by increasing PVRIP. The patient must have electrocardiographic conduction to have this pacemaker mediated tachycardia or ERT. And pacemaker must be programmed to a tracking mode. And these are some management. I think we can discuss this. Management of pacemaker include a magnet. We can terminate it by magnet by increasing the PVRP more than the retrograde conduction time. For the sake of time, because I was supposed to end at 9 p.m., I think we have our French people who want to also present in 1 hour. I think I can end here, but you can analyze this with the problem and know the parameters, the impedance, the threshold, and guess at least where could be the problem. For example, in normal lead, the impedance are normal and the voltage threshold are normal. When you have lead displacements, the impedance are normal, but the thresholds are high. When you have lead fracture, the impedance are high and the voltage thresholds are also high. When you have lead insulation defect, the impedance will be low and the voltage threshold high. So this can be clue of what can be happening in your patients in terms of complications. Pacemaker syndrome is also common. It's due to inadequate timing of atrial and ventricular contraction, and it causes reduced cardiac output and hypertension. It occurs in patients with VVI of about 10 to 20%. And these are symptoms. And you can diagnose it by comparing blood pressure during AV synchron and during ventricular pacing. A drop of more than 20 millimeters of mercury during VP is a diagnostic. Pacemaker syndrome in VVIR will only occur during exercise, and the treatment of pacemaker syndrome, including, is to restore the AV synchron by performing a DD pacing. So, in that nutshell, I would like to end here. I will open room for discussion and for inputs from Professor Mevat and other senior colleagues. Thank you so much for listening. I can now stop my slide.